A very good evening, one and all. So, in continuing with our ongoing series of lectures, webinars on extracorporeal membrane oxygenation from eminent faculties across the world, now we have actually reached a point where we are talking about much advanced modalities of extracorporeal membrane oxygenation. Now, today we'll be actually discussing about what is known as post-cardiotomy ECLS. Post-cardiotomy ECLS is nothing but instituting a patient on extracorporeal membrane oxygenation after a cardiac surgery. So, for us, we are actually going forward today, and we have invited a very eminent faculty member from the Netherlands, who is actually a pioneer in post-cardiotomy extracorporeal life support, Dr. Roberto Larusso. So the thing is, we are happy to announce that Yashoda Hospital has been awarded the Platinum Center of Excellence, and we will be awarded this eminent honor next week. So continuing with that festive spirit from our end on the achievement of what our ECMO team has achieved. So we'll be continuing with our advanced extracorporeal membrane oxygenation webinars. So due to a travel commitment which was made prior by Dr. Roberto Larusso, he was unable to join us today live. So we have actually requested him to give a lecture to us a couple of hours prior when he was actually free, so which he has gracefully agreed to. And we happened to record that lecture, and now we'll be giving we'll be giving that lecture for us. So let us actually go into the academic part of it. Let us see the lecture, and we'll let us understand more about post-cardiotomy ECLS supports. Over to the digital team.
Thank you for the kind invitation. It's a privilege for me being with you all today. I am a cardiac surgeon, and that's the reason why I am familiar with this type of setting and field, which is a post-cardiotomy use of ECLS or ECMO, as you would like to call it. These are my disclosure. So I would like to address a few learning objectives during my presentation. So the first will be about the description of the use, definition, and recognition of the problem, which is characterized by the post-cardiotomy ECLS. Then we have to discuss about complication, some clinical series. Then we have to characterize some aspects which are very important. You will understand why. Because, of course, we have to identify how to improve this utilization. And finally, I would like to announce a few things still under embargo, but I can announce some new release, which are, I think, going to be very important for this field. So just to give you an idea about the relevance of this problem, this comes from Valabayosula and colleagues. They look at, you can see from the title of this paper, about the trends, predictors, and outcomes about the use of temporary mechanical circulatory support in post-cardiotomy or post-cardiac surgery cardiogenic shock. And you can see here, this series was looking from 2005 to 2014, so it's already 10-year-old, but just to give you an idea about the increase of use of post-cardiotomy shock and ECLS, but post-cardiotomy shock prevalence increase almost 180% in a 10-year time. So just to give you an idea how important, how the increase of post-cardiotomy shock events are really impacting cardiac surgery. And by the way, post-cardiotomy shock was the most frequent indication for ECLS in USA. So these two information just give you an idea about the relevance, about the impact of post-cardiotomy shock in cardiac surgery. But unfortunately, there are not some good news. This is Glenn Whitman, who published just in 2016, and he looked at the ELSO registry data. As you can see, the number of ECLS or ECMO in post-cardiotomy patients is continuously increasing. But unfortunately, you can see here the survival, which was really, really poor. And I will go back to this data later. But let's have a look from this let's say, publication. And you can see here that the use of post-cardiotomy was mainly performed in post-operatively. And I will highlight this because this is a very critical issue. So the majority of post-cardiotomy ECMO cases were performed after surgery. But this is just one of the aspects we have to underline. Another aspect you can see here, central, again, 60%. So the majority of post-cardiotomy cases, the cannulation, the arterial cannulation was performed on the central aorta, not in the femoral or axillary arteries, so not peripheral. And this is another important aspect. Then, as I mentioned in my objective, so the table of contents for this presentation, we have to be absolutely aware and acknowledge that unfortunately the complication rate or rates were really, really important. As you can see, renal failure, 65% of the patient, reoperation, mostly for bleeding, 64%, and so forth. And leg ischemia, 20%. So again, these are very important numbers, highlighting that these patients are obviously in a very, very complicated situation, but the use of ECMO sometimes can even further deteriorate the situation. And as mentioned before, look at the survival. So the survival at ECMO, through ECMO, was 63%, so not that bad. But look at discharge. So between ECMO weaning and the discharge from the hospital, were almost 40% of the patient dying. And at the end of 6 months, only 16% of there were survivors. So very, very disappointing numbers. And this was mentioned by Professor Whitman about the gaps of knowledge and what was in 10 years ago, what were the elements, the aspects, the factors to be investigated, as you can see in this list. And all these points were really, all these items were so important. And I think that I'm not sure that all these important objectives mentioned 10 years ago have been fulfilled so far. Well, as I told you, I am a cardiac surgeon, so I was deeply, deeply involved in the evaluation and assessment post-cardiotomy ECMO. And to do that, we started a few years ago, and we published in 2019 in the Journal of Heart Lung Transplantation a very thorough review of the papers regarding post-cardiotomy ECLS in adult patients. And we found out that the rate of, or the prevalence was between 0.4 and 3.7%. So again, not really common, fortunately, but still not negligible. And this, again, going back to the Valabayosula paper, we can see that the trends of the use of ECLS, the type of ECLS, changed quite dramatically along the years. And you can see here that the use of ECMO increased along the time, but you can see from the above curves, the red and the blue, the intraortic balloon pump continuously declined. So there was an increase in the more powerful devices like ECMO, like Impella, and the reduction of the less powerful like intraortic balloon pump. Although in US, the EIBP is still very much used, whereas in the Europe, because of the SHOCK 2 trial, who showed that there was no difference between balloon pump and medical therapy in post-acute myocardial infarction cardiogenic shock, the use of EIBP decreased remarkably. But we have to consider one thing. We are discussing about a patient in cardiogenic shock. But is the patient in cardiogenic shock after cardiac surgery equal to a post-acute myocardial infarction or acute myocarditis or pulmonary embolism? Well, that's not unfortunately the case. And this was highlighted in a paper published 5 years ago. And you can see this was an expert consensus document released, or let's say realized by 4 society, CTS, or the European Society for Cardiothoracic Surgery, ELSO, STS, and ATS from US, and had the privilege and honor to chair this task force. And what we absolutely highlighted is that post-cardiotomy ECLS patient or ECMO patient is absolutely peculiar, because besides the cardiogenic shock itself, which is obviously a critical condition, there are a bunch of, you can see here, high-risk situation and conditions which further negatively impact the potential outcome and ultimate outcome of these patients because of many other negative factors. So these patients are particularly at very high risk, at higher risk than other cardiogenic shock patients to have a very dismal prognosis. So just a few clinical series. You can see here, this was another publication of my group with Mariusz Kowalewski, one of my PhD fellow at that time. We look at the post-cardiotomy shock ECMO use in the ELSO registry. And you can see here, again, clearly showing that there was a continuous increase in the use along the let's say almost 20 years. But unfortunately, you can again clearly recognize that the mortality, in-hospital mortality rate was again disappointing, with almost 60% of the patient dying, or if you want to say, only 40% of the patient undergoing post-cardiotomy ECMO surviving the hospital admission. This is another investigation we did on the Dutch registry, so the Dutch Registry of Cardiac Surgery, and we look at the patient undergoing post-cardiotomy ECMO, and you can see a little bit more than 400 patients, and again, unfortunately, we confirmed that in-hospital mortality in this study was a little bit better, but you can see almost 52%, not 50%, 60%, but still very high. But what was instead positive is that once the patient was released or discharged from the hospital, the post-discharge outcome was rather favorable. We could also find out some negative predictors for in-hospital survival, which were older age and higher BMI, and for the post-discharge outcome, the presence of post-renal failure, post-op respiratory failure, and rethoracotomy during the hospital admission were negative determinants for long-term outcome. Then we decided to do something more. So we looked at the ELSO registry, but that was only confined to the in-hospital data because ELSO registry does not have follow-up data. Then we had the Dutch registry, but we decided to have more than 400 patients. So we organized the PEL study. The PEL study was a retrospective international multicenter study. And you can see we were able to collect more than 2,000 patients with 34 institutions in 16 countries. That was a real big study, real big effort. But I will show you that this was extremely important and useful. This was the first publication about the overall, the main studies. This was published in the Journal of American Heart Association. And you can see again that our study, our registry, retrospective study of 2,000 patients, more than 2,000 patients, we actually confirmed the ELSO and Dutch registry data, confirming very low in-hospital survival rate, as you can see. But at the same time, a positive information that once the patients were discharged, the post-discharge outcome was favorable, as you can see, with very low or very few deaths. A very important aspect that we found out in our investigation, not only in our series, but in the investigating also the literature, the importance of timing. This was first highlighted by Thomas Fuchs and colleagues in Stockholm, and they look at risk factor for mortality in post-cardiotomy ECMO. And you can see that in the ischemic heart disease, they found out that if the patient was submitted to ECMO with a lactate below 10, the prognosis was more favorable compared to patients with higher lactate level. But this was even more striking or different without ischemic heart disease, or like valvular surgery or aortic surgery, and you can see the remarkable difference about lactate. So again, the implant of ECMO before the patient developed a very high level of acidosis was extremely important. So timing here was really, really critical. This was also highlighted by Embry and colleagues from the Columbia group in New York, but they look only at tricuspid valve surgery outcome. And what they compared patients undergoing mechanical circulatory support early or late. And what they found is that the early group received the early support was characterized by very low level of VIS score, V-score, as compared to the late group, meaning that these patients, so the early group, had a much lower level or catecholamines or inotropic or vasopressor. And by the way, the late group was associated with higher in-hospital mortality, as you can see. And as said, the late ECMO group also had a higher peak V-score. So to summarize, the early group, the early patient, the patient who had early support had lower catecholamine use and dosages, and also a lower in-hospital mortality. We look again at the timing with the PELS study, one of the sub-studies we performed, and what we, let's say, compared was the implantation intraoperatively or postoperatively. And what we found out that the postoperative ECMO was mainly characterized by the cardiogenic shock, but particularly cardiac arrest or right ventricular failure. The ECMO was usually implanted between 24 and 48 hours after surgery, and this patient had more complication and more intervention. Whereas the patient who underwent ECMO implantation intraoperatively, despite the worse preoperative risk profile, they had a shorter ECMO heart, there were less complications, they had higher in-hospital survival. So this, again, underlying that timing was really critical. So the earlier, the better. And you can clearly see a difference. So the comparison between intra and postoperative implant of ECMO, and you can see the difference, 34.1% versus 42% almost during support, during ECMO. And then also you can clearly see the death rate, unfortunately, after weaning, which was higher than 22%. But finally, you can clearly see the difference of in-hospital survival, which was 42.8% in the intraoperative group versus 35.8% with a p-value which was highly significant, as you can see. So this post-cardiotomy ECMO gap, which is the post-cardiotomy ECMO gap, is the patient who are successfully weaned from ECMO, but they still die in the hospital. So they die between successful weaning and obviously the patient discharge. So in that period of time, we call it ECMO gap. So they were successfully weaned, but they still die. And this was, again, one of my PhD fellow, Majid Makul, And you can clearly see that this is absolutely what we mentioned before. This is a huge, huge problem that we have to absolutely address, because from the ELSO registry, almost 40% of the patient died between ECMO weaning and hospital discharge. And indeed, we, through the PEL study, we look when the patient died, on support, so during ECMO or after ECMO weaning. And you can clearly see again that the patient who died on support was 33.6%, but the patient who died after successful ECMO weaning was 23.1%. So a very, very high number, which should really attract our attention and efforts to improve this absolutely disappointing data, as you can see. And the causes of death. This is another important difference. As you can see, the causes of dying, why the patient died on ECMO during support, you can see multi-organ failure and persistent organ failure. But the causes of dying after successful weaning were the same, so persistent heart failure and MOF, so multi-organ failure. But the very important part was due to sepsis. So infection was really a very important aspect for patient dying after successful ECMO weaning. Another interesting study with the PELS database was looking at a patient who died because they had cardiogenic shock or cardiac arrest in the ward, not in the ICU, not intraoperatively. And you can see here again PELS database, and we had only 39 patients who were cannulating the normal ward, so who would experience cardiac arrest or cardiogenic shock after being discharged from ICU in the ward. And you can see here that unfortunately, the hospital survivors were really few, only 6 over 39, and the vast majority of patients died. And you can see here the vast majority of patients, or the causes of cardiogenic shock was, or decompensation was cardiac arrest and cardiogenic shock. And you can clearly see that this is a very complicated, very, how to say, dismal prognosis for these patients. And you can again see that at the end, only 15.4% of patients were discharged if they had to be cannulated in the ward. And you can see the Kaplan-Meier too. But again, we can absolutely confirm that once these patients who survived this very huge storm, after discharge, their outcome is really favorable, as you can see. So how to improve these very disappointing results? We think that the LV venting on ECMO plays a very important role, and it was absolutely underutilized in post-cardiotomy ECMO. And indeed, this was highlighted by Radakovic and colleagues, and they show that if you had ECMO plus in this case Impella, or ECMO only, the comparison, you can clearly and visibly recognize that the outcome was more favorable in the patient who received ECMO plus LV unloading. So what about the configuration? I mentioned central, peripheral. Well, this was a very nice study from the Vienna group at that time with Dominic Wiedemann and Anne-Christine Schaffers. And they look at more than 570 patients, and they look at the 30-day, 1-year survival, comparing axillary artery and femoral artery. And you can clearly see that there was no difference in this outcome, but looking at the complication rate, you can clearly see the axillary artery cannulation was associated with a much higher prevalence of brain injury, whereas, as expected, the femoral artery cannulation was associated with a much higher limb ischemia, which was very low, below 5% in the upper arm in the axillary or subclavian artery cannulation. In our study, looking at the ELSO registry, we saw that the peripheral cannulation was associated with a much better in-hospital survival, and the central cannulation was associated with a high rate of bleeding. And indeed, bleeding is a major issue in post-cardiotomy ECMO or ECLS. This is again the same group from Vienna. They look at the impact of bleeding and thrombotic complication in post-cardiotomy ECMO. And you can clearly see that the differences between patients who had no of such events, so no thrombotic or no bleeding events, so the green area, and you can see the thrombotic events were obviously with a lower survival, but the worst were the patient with bleeding or both complications you clearly see. And you can again see the type of bleeding events and thrombotic events, but the bleeding events were absolutely the majority of these complications, as you can see. And again, looking at only the bleeding events, look at the difference between patients who had no bleeding event versus patients who had a bleeding event. Again, highlighting the importance of such a complication in post-cardiotomy ECMO. We had also a look at our experience only in 10-year time from 2007 and 2017 for post-cardiotomy. And you can see here how was, let's say, frequent the complication of bleeding in the early years of 2007, 8, and 9. And then, fortunately and gradually, this complication was reduced. And honestly, when I arrived in Master in 2015, I was really obsessed by such a complication. I tried to, implement a protocol which was really tough protocol to try to reduce remarkably this complication. And I can tell you that now we have a complication rate which is lower than 10%. And is this a sort of a benefit for this patient? Absolutely, yes. You can see the type of, hospital survivor if you had less bleeding events. As you can see, the hospital survival went up very much. This was because the 2017 was only the first 4 months. But you can clearly see that hospital survival was very low, up to 25% only, and then it went up and up following this, as you can see. And why? Because we applied a very thorough protocol. So full intraoperative protamine dosage, so complete reversal of heparin, maniac hemostasis. We don't go to the ICU from the OR until we see that the hemostasis is perfect. We close the sternum, very important, even with central ECMO. The cannulas are passing the jugulum. We want to have the sternum closed because that is one of the most important source of bleeding. Then we don't use heparin for at least 24, 48, even 72 hours until we see that there's no bleeding anymore. And then we use a point of care anticoagulation control and management like ROTEM. So what about age and body size? This was a paper from Biancari and another consortium, and they saw comparing patients below 70 years and 70 years or above. Obviously, the older patient had a much higher in-hospital mortality, but this is obviously acceptable. I mean, it's something that we expect. And also the moment of death was mainly during support. But I would say that this is not discouraging the indication of ECMO in this patient. We look with the PELS study again, with the PELS database, about the relation between obesity and mortality in post-cardiotomy ECMO. You can see again, more than 2,000 patients. We divided the patient according to 6 BMI classes according to the WHO guidelines. And what we saw that neither mortality nor major adverse cerebral events was different in all these classes. Again, this showed us that the obesity is certainly not a contraindication for ECMO, even in the class 3, so in the morbid obesitas. What about duration or bridge 2? Again, this was the Distelmeyer and colleague and Dominic Wiedemann looking at duration, and they look at more than 350 patients, median follow-up 45 months, high mortality. And they showed that the far-above active duration was 7 days. Above 7 days, the patient prognosis was really dismal, as you can clearly see. So you can clearly see that the best patients were the ones who could be decannulated or weaned in 3 days. And then gradually, the outcome of this patient decreased or deteriorated. And you can see that after 7 days, this group of patients had the worst outcome. And this is well known because the more you go on with venous arterial ECMO, the more you will be exposed to thromboembolic and bleeding complications, as shown by Rastan and colleagues from Leipzig at that time. Going towards the end of the presentation, I want to say something about the patient informed consent, because many patients are at high risk for perioperative low cardiac output syndrome. We know that. And we should inform this patient that maybe they are at high risk to be supported after surgery. And they have the right to also say no to this kind of support, as they can say, I don't want to be resuscitated, for instance, do not resuscitate protocol. And this would be the same for mechanical support. You can have limb ischemia and limb amputation, and maybe the patient would not absolutely accept this type of life. And so it should be informed. If you know that this patient is at risk for a post-cardiotomy mechanical circulatory support, and you can see here, we have to increase the knowledge and also have a right time to discuss that. Because we know there are patients who are at the unlikely, let's say, chance to have a sort of a mechanical support, like routine cardiac surgery patient with no negative or risk factors. But if you have a patient with very likely use, then we should absolutely discuss with the patient, the relatives, and then you have the very high likely risk. And in this case, absolutely, you need to have all the description, all the discussion with the patient relatives and get the informed consent about the use of MCS. Now, there are new studies. We want to do randomized control study in post-cardiotomy, like central versus peripheral, preoperative ECLS in ventricular septal defect, protecting MCS in high-risk patients. And this is the most important issue I want to conclude my presentation, preemptive mechanical support. I showed you EMBRE before, the early and late support, but this is what I like of these two editorials, and I really suggest you to read. Because in high-risk cardiac surgery patients, I think we have to absolutely explore a new paradigm. A new paradigm which means preemptive support. And this was very, very nicely highlighted by Jonathan Huff from Ann Arbor, which means that you don't have to come late to the party. I mean, party is a little bit an empathic word, but you don't have to arrive too late. Actually, you have to arrive early. And indeed, this is what we are going to do with the European Society Association for Cardiothoracic Surgery. I had again the privilege of chairing the document task force with Leonardo Salazar from Colombia, who is the document coordinator. And this paper, which is the so-called protected cardiac surgery, so the use of mechanical circulatory support, preemptive, prophylactic, in patient high risk for postoperative low cardiac output syndrome. And this will be presented in a couple of weeks' time in Copenhagen, in Denmark. Sorry for this mistake, in October, because we are now defining the type of protective cardiac surgery phases and modalities. And this is unfortunately under embargo. I cannot present you more than that, but I tell you, this will be a big change, a paradigm change in the daily practice of cardiac surgery in high-risk patients. You can find all this information I gave you today in this very nice monograph published by ELSO about post-cardiotomy ECLS and other temporary mechanical support in adult patients. So in conclusion, I think that I showed you clearly that the use of post-cardiotomy, so the occurrence of post-cardiotomy cardiogenic shock and the use of ECMO is absolutely increasing, but unfortunately, the outcome, which is quite rather disappointing, has been stable and no improvement in recent years. Furthermore, we showed that despite the very low in-hospital survival, if the patient is discharged, the long-term outcome is really favorable. But we have also to recognize that we are going to operate older and older patients and also more complex patients. Sometimes in the past, these patients were considered inoperable. Now we operate because we think that ICU, the surgical techniques are improved, but still we are facing more complex patients. In this situation, strategy and timing for ECMO in post-cardiotomy cardiogenic shock is absolutely essential. We have to avoid certain complications, bleeding for sure, but other type of complications should be addressed and hopefully prevented or at least reduced. This will change completely the outcome of this patient. And you could see that there is a very high rate, more than 22% of patients who are successfully weaned but still die in hospital, which is called the ECMO gap. We really need to do something for this kind of patient. Then LV unloading, I showed you, is apparently beneficial, although we should confirm with additional studies, but we have to do more in that respect. And I think this aspect, strategy and timing, bleeding or complication control prevention, the ECMO gap, and LV unloading, these are very important factors to improve the in-hospital disappointing results of post-cardiotomy ECMO. And I thank you for your attention.
So you, in one of your slides, you were mentioning that there is a role of lactate to have mortality implications. So what is the ideal time at which we decide that post-operatively this patient is going to require ECLS support?
Well, I showed that study of Fuchs and colleagues, but the study showing that if you have a high lactate, usually above 6 or 8, the study of Fuchs was 10, the patient had very bad, worse outcome is well known. So the ECLS should be implanted as early as possible. A lot of people, of course, are using high inotropic dosages, and this usually, keeps the time going on and the lactate's rising. So I think that if you have a patient in post-cardiotomy cardiogenic shock in the OR, first of all, in the OR, you try to, fix the problem with one inotrope, you increase the dosage, but if you see that the dosage is still increasing and you have no effect, you don't have to pass to a second inotrope, but you should go on temporary mechanical support and not waiting for acidosis, so not waiting for lactates going above 4, 6, certainly not 8, and then you are in the OR. So you are in a protected environment, you are absolutely there, everyone is there, so you can perform everything under control conditions. If you wait and then you start increasing the dosages, increasing the number of inotropes, then you go to the ICU, the patient is unstable, hypotensive, then you are in the ICU, so you have to go back to the operating room or implant the ECMO in the ICU, not favorable condition, not favorable environment. So this usually brings the patient in a very acidotic condition, which is a well-known risk factor. So you don't have to wait. You can try to use conventional and, not aggressive, let's say not mechanical circulatory support condition and use drugs, but not at the expense of waiting and waiting and waiting, because this will bring the patient to a very, very bad, let's say, hemometabolic conditions, and then the patient will not react even to mechanical serial support. So if you ask a number, I would say that when you see the lactates going above 4, above 6, then you don't have to wait anymore. You have to go and start a mechanical serial support. And particularly, I would say you can, think of, for instance, only 11 ventricular support like Impella 5.5. But I think that it also depends on the type of dysfunction. Is it a biventricular? Is it a univentricular? Is it right? Is it left? So, sorry. So you have to consider a lot of factors, but as soon as possible, very quickly, you have to have a shock team. That is also important. Surgeon, cardioanesthesiologist, ICU, and cardiologist. These are the people, and the perfusionist as well. So this team should look at the patient, very quickly take a decision, but usually when you see lactates are going high and higher and higher, no increase in the vasopressor, you should go to mechanical support. Actually, this should be done to decrease the dosages and the number of vasopressor. Any further question?
Sir, one more thing, sir. So when do you think is the best time for us to transition to a more durable support like VADs, ventricular assist devices, in
As we
patients who are
saw,
already on post-cardiotomy ECLS?
So for ECMO, you should not go beyond 7-8 days, because we know that ECMO with above that kind of period can bring to a lot of complication. And also depends on the etiology. If it was a post-cardiotomy because of myocardial infarction, and you think the patient can still recover, then you can put an Impella 5.5 and be on support for a longer time, like even 15, 20 days, even 30 days. Not certainly with ECMO. ECMO should not go beyond 7-10 days maximum. After that period, you will have a lot of complications. So you have to consider a change of the temporary mechanical support, and also look at the possibility of the patient to recover. If you think that the patient will never recover, then the sooner the better to consider a more advanced therapy like LVAD or RIVAD or transplantation.
Presentation saying that these patients will have persistent heart failure is one of the reasons.
Yeah, right ventricular failure.
So, do you think that we should actually cause any revision in the weaning criteria in post-cardiotomy ECLS patients, sir?
So, right ventricular failure is the responsible of post-cardiotomy ECMO in the 20 to 30% of the cases. So it's rather frequent and common. Also in this case, a very early support is absolutely important. Regarding weaning, well, there are some aspects to be considered, and of course they are different if you have a left ventricular, right ventricular, or biventricular dysfunction for the weaning trial. So you have to follow the echo, you have always to follow the Swan-Ganz catheter criteria and data. So you have to have the echo showing you the VTI above 10, 12, usually 12 will be better, at least ejection fraction of 20-25%, at least no increase in drug therapy, in drug dosages. The O2 saturation, venous saturation, oxygen saturation should be maintained and not increasing, so decreasing actually. So you have to look at all these aspects together. But the most important is echo control, Swan-Ganz catheter data, and then you will have all this situation under your assessment and judgment. Usually, if you have an ECMO, if you have an ECMO, it would be nice to have some other devices like Impella or intraoperative balloon pump to make what I call it a soft landing. So you are on full support, you reduce support, but you still maintain a temporary mechanical support with a lower aggressive. So like, as I said, the intraoperative balloon pump or Impella, which would be even better. So these are the way I think you should manage the weaning, because as I said, more than 22-23% of patients dies after successful ECMO weaning. So maybe this weaning is performed too early, and a prolonged time of partial support would be absolutely beneficial.
Final, last question. So the thing is, there is you have mentioned the difference between a central cannulation versus a peripheral cannulation, where the peripheral cannulation axillary versus femoral. So, like, what is your experience with putting a graft to the femoral artery than to the axillary artery? So, which probably, in your experience, does it bring down the limb ischemic complications, or you prefer deep perfusion?
That's a good question. I mean, central cannulation usually is associated with a higher bleeding rate and therefore a higher in-hospital mortality, because most of the time central cannulation is associated with a sternum which is left open, and this is obviously a very, very bad condition. It favors bleeding, it favors infection. So if you perform central cannulation because you don't want to change the cannula, okay, you can do, but you have to have the cannula out from the thorax, not leaving the sternum open. You can go to the jugular, which is usually what we do in this situation. Regarding the use of graft, absolutely, the graft at the axillary artery is usually what it's done for cannulation of the axillary artery. Much less frequently the graft on the femoral artery. But I mean, if you perfuse the distal limb with an additional catheter or additional cannula, there's no real need of putting a graft. But we know that if you perfuse the femoral artery with a graft for the return, the perfusion return, their limb ischemia rate is absolutely lower. I think it's a very good method, but it's also associated with a higher risk of infection. So again, I think that the limb ischemia in the upper limb for axillary cannulation is really very low, below 5%, 4%. Instead, the limb ischemia of the leg is above 15-20%. So this is absolutely much more, it's higher concern. So I think you must always perfuse the distal limb in the leg. You have to use, we always use the pediatric cannula, 9 or 10 French, not the 6 French introduction sheet. I think the pediatric arterial cannula is much better. Or you can use, we use now the biflow cannula from Livanova, which is very useful. We have almost 100 patients perform with this cannula very, very effectively. But you must perfuse all the time the leg. The upper arm, that's not an issue if you go on the axillary artery, because most of the time you go with a graft, and this is not an issue for the arm. So again, always perfuse the limb, particularly the leg.
So what will be your anticoagulation targets? Because you are running a heparin-free ECMO for 72 hours. What are your anticoagulation targets?
The anticoagulation, again, as soon as after surgery, no anticoagulation, absolutely, full protamine, no heparin, until you see that from the drainage, you have no blood, so no bleeding, which could be 24, 48 hours, absolutely heparin-less management. As soon as you see that there's no bleeding, then you start, and our ACT is between 160 and 180. So this is what we usually do. And of course, you have to keep platelet for sure in the post-operative period above 70, 80,000. And this is absolutely something you have to do. So
thank you, sir. Thank you for your time.
Thank you very much for the kind invitation. And well, we'll see. I hope soon. We'll see each other. Thank you very much.
So that actually brings us to a conclusion for one of the very comprehensive discussions on a rather difficult topic on the post-cardiotomy ECMOs. So I think I see some strategies or open questions, central versus the peripheral cannulations. So it has been mentioned very clearly that central cannulations are associated with much more bleeding complications versus the peripheral cannulations. But even if you are preferring central cannulations, it's according to our distinguished speaker, it is always better to get them from the thoracic side and always keep the sternum closed. So venting strategies, from where they come from, whatever I know, they have actually preferred Impella as a venting strategy in many of these patients. But however, because venting Impella has been significantly associated with very high cost issues for us here, there are certain surgical venting strategies where you can actually vent the left atrium from the left superior pulmonary vein. Transapical venting strategies are not so preferred given the state, because if the patient is having an acute MI or anything, getting a transapical venting strategy into the left ventricle might be associated with some thrombus formation around the vent, and also associated with some non-healing part when you are actually trying to remove the vent. Sir, any other comments from panelists? If there are no further comments from panelists and no further questions, we will close the session. Thank you.